All right, we're going to go ahead and get started. We're just a little bit late, but I wanted to go ahead and we want to talk today about some dry needling of the rotator cuff and tendinitis associated concerns, issues with the shoulder. A lot more things that we do dry needling in the shoulder, but we're going to focus on some anatomy, some surface anatomy, and some common things that we'll see. And we'll do a live demonstration of the rotator cuff muscles themselves and the tendinous attachments onto the humerus itself. So let me go ahead, and I want to share my screen real quick, and let's talk a little bit about the structures that we're going to deal with. So obviously just an overview here of everything that we're going to talk about. This image has the deltoid in place. We're going to take that away and see if we can see a little bit more of the structures that we're going to interact with. So as we take those away, here we are with on the top the supraspinatus coming down and its attachment onto the humerus. We're not dealing with them today, but we will talk about them. The subacromial subdeltoid bursa when we're dealing with impingement, that along with the coracohumeral ligament or coracoclavicular coracohumeral ligament, we can do some work with those as well to decrease that impingement. But supraspinatus on top, we'll go ahead and needle the infraspinatus below the spine of the scapula, and then below teres minor. Teres minor is very infrequently involved when we're dealing with, clinically, when we're dealing with rotator cuff concerns. And then on the anterior aspect of the scapula, you can see the tendinous attachment of subscap. And so again, just highlighting those muscles, supraspinatus up top, and we'll go over our needle placement and location with those. Infraspinatus below that. My computer has stopped. Oh, here we go. Infraspinatus just below and with its insertion below that. Teres minor, again, not frequently involved, but never a bad idea to go ahead and include that in your needling if it's indicated. And then subscap itself, which can be needled from an anterior approach or from a posterior approach for the muscle itself. Moving down, let's look a little bit further at some of the other issues that can be involved. Definitely we're interested in the myotendinous junction of each of the muscles. Frequently we can see tearing at the tendinous junction of each of the muscles of the rotator cuff. And when we're dealing with the tendinitis aspects, that's where our needle placement will be, as well as in the muscle itself. Additionally, frequently if there's a shoulder issue, there can be an isolated or a concurrent AC joint issue. I do frequently find benefit from needling both the capsular issue and deeper into the AC joint itself. Again, we discussed the subacromial and then subdeltoid bursa. In this diagram, it's showed separately as two different bursa. I think we recognize that it's probably one continuous structure, but for our purposes here, we're going to two different ways of needling it, either as individual structures, or we can deal with them all in one needling approach. Coracobrachialis, which sits right behind the short head of the bicep. A lot of our issues in the shoulder anterior pieces, we do seem to see the anterior stuff moving a little bit more medially onto the coracoid, and so addressing those two muscles themselves can be an issue. Occasionally we can also palpate into the pec minor. We may find that that shoulder issue extends over to that area as well, so frequently that can be helpful for that. And then the long head biceps, of course, with its attachment on the glenoid, running through all of the structures there. A lot of times if you're avoiding the bicep itself, especially the long head, then you could be missing clinically out on some key pieces that need to be dealt with. From the ligamentous standpoint, the coracoacromial ligament, obviously with impingement, creates a lot of, especially if it's thickened, can create a lot of, take up a lot of space in that area. Surgically, the surgeon's going to go in there on a repair or just a debridement as well and remove that. And so if there's a thickened ligament with an impingement especially, we probably do want to take a little time and address needling onto that ligament itself. That one usually is more of an issue than the others. However, the coracohumeral ligament can also be an issue. And so fairly easy coming from the superior aspect to needle that as well. The trapezoid ligament coming off the medial aspect of the coracoid, and then from the posterior aspect, the conoid ligament. All of those can play a fairly key role, but again, usually either the coracohumeral or the coracoacromial ligament are more concerning for impingement and space occupying concerns. When we are talking about the supraspinatus, what we're basically going to do is palpate for the spine of the scapula, and we're going to move just a little bit anterior to the spine of the scapula. We want to be cautious with our angulation and our placement. Obviously, as you can tell, if we go anterior, we're getting a little bit more into the potential to enter the lung field and possibly into the neurovascular bundle as it's traveling right there. So proper placement is critical for that. Moving to infraspinatus, get that screen up. A really nice location is just inferior to the spine of the scapula. Usually get our best results there. There are patients who will have issues a little bit further distally in the muscle of the infraspinatus itself. So there are times I may needle further down, but usually my go-to is just right below the spine of the scapula. On teres minor, we're just going to go about midway on the the lateral border of the scapula, and then the upper half of that distance we'll palpate for teres minor, and right in that place, that space, just barely lateral to the lateral border, we can needle into the teres minor. Obviously, we're going to probably catch some posterior deltoid. We're going to catch some other muscles along the way. If we needle deep enough, we may even catch a little bit of the tricep, head that's traveling right there. And then finally, we're moving on to the subscapularis. Really two different ways we can needle through that. The one we'll demonstrate today is in a prone position. We will needle, we'll go into the hand behind back position and needle underneath the scapula with the needle landing on the anterior surface of the scapula. Obviously, again, we're going to needle through some rhomboids. We're going to needle through a serratus, but ultimately our target will be subscap. We can also catch it, as you can tell, anteriorly with the arm extended. So here you can tell our needle location on the anterior surface in the prone position, but in supine with the upper arm at about 90 degrees and externally rotated, you can definitely catch the fibers of the subscap in that area. Just being cautious of the neurovascular bundle. And then, again, we talked a little bit about the bursitis, subacromial, subdeltoid, impingement-related concerns here. With that, again, would also deal with any of the ligamentous structures, coracoacromial and coracohumeral, but definitely along the tenoosseous junction of the muscles, the humerus here, and the line is not represented here, but on subscap as it attaches anteriorly as well. So let me move on to one other thing. So what we're going to look at is, let me move on from here. The primary structures, what we're going to deal with today, supraspinatus, infra, subscap, and teres minor. We've talked about the tendons and ligaments. We're not going to needle those today, but we may look at doing a separate webinar on impingement and dealing with those structures specifically. Secondary muscles and structures that clinically that I look at whenever I'm needling frequently will involve the rotator cuff myotendinous junctions, which we actually will do today. Again, short head of the biceps and the coracobrachialis, long head of the bicipital tendon. We can get some tendinitis in that area, and frequently we want to needle that depending on what the problem is. AC joint, a lot of times we need to get in there. And then again, the bursa, subdeltoid, subacromial. One of my things that I always tell both my clinical staff and then the students that take my courses is dry needling is a fantastic tool that we use, but it's just that, it's just a tool. Our goal here is reduce low-grade muscle tension, muscle spasm, create a situation of a healing inflammatory response in these local areas, and without throwing in then the manual therapy, the exercise, the movement-based approach. After that, then we're going to decrease pain short term, but we're not going to make that mechanical change that we're looking for. So using this as a tool, step one. Step two is the traditional manual and exercise movement-based approach that we need to look at. And so for a little humor, I'm now going to use my needles. So let's talk a little bit before we get to the table on supraspinatus. A good idea with a new patient is to always have your patient in prone, especially the first time that you're needling because of potential issues with a vagal response, lightheadedness, passing out, things of that nature. If they're in prone or supine, much less likely to have that sort of response. And then you having to manage your patient while you're also having needles inserted. So for this situation, we're going to do this in prone. Again, beginning needler is always a good idea. Needle length, we're going to look at about 3 centimeter for a small person. We'll get the proper depth that we're looking for. For a larger person, 3 centimeters may not be quite deep enough. However, for safety, a 3 centimeter needle in this regard will always be a good, safe approach to begin with. Our backdrop is going to be on the supraspinatus fossa, and precautions here, definitely the lung field. So we'll walk through that posterior angulation of that needle. In the process, we're just going to palpate the spine of the scapula, and we're going to, and I'll demonstrate this, but we'll move the needle anteriorly as once it's in the skin, so we can get a posterior direction and be certain of our location on the spine of the scapula, and then we'll drop it just a little posteriorly. Infraspinatus, quite simply, we're going to drop 1 finger breadth distal from the spine of the scapula in about a midpoint, and again, our concern here is lung field. As long as you are in that mid area, you should land on the infraspinatus fossa and not have any potential complications there. But we will drop to the depth of that scapular border. For subscapularis, we're going to go in a hand behind back or hammerlock position. We're going to try to pull that medial border away from the rib cage, and then we'll angle our needle to the anterior surface of the scapula to needle onto that subscap itself. Again, as we discussed, it can also be done in an anterior approach if that's desired. If I'm needling all of these other structures here for patient comfort, I usually will go ahead and needle it in that position. With these, always, because we're very close to the rib and the lung field, you want to make certain that your needle angulation is in a parallel line with the rib cage or a little bit away from it, definitely not entering into the lung space. And then teres minor, again, here we're concerned about the axillary neurovascular bundle, the potential for the lung field. We're going to needle lateral slightly away, and we're just going to grasp those muscles as described and we're going to feel for the most tender spot, and then needle. Our fingers on the backside are going to be our backdrop. So as we approach and we feel like we're getting close, we will be able to palpate that, and then we will perform the needling to that depth. The subdeltoid bursa, we've mentioned this here. This is assuming that there are two different structures. We can move one finger breadth lateral from the lateral edge of the acromion and just in a superior to inferior direction, needle onto the humerus there. Now, that will also give us one of the needle locations if we're dealing with the supraspinatus, the tendinitis approach as well. So we'll drop onto that junction when we go after the subdeltoid bursa. Subacromial, we'll drop one finger breadth down, and really what we're going to look for is that space in between the humerus and the lateral edge of the acromion, and we're going to have a slightly superior angulation to go into that space. And then for the tendinitis aspect, as you can tell, we're just going to locate where each of the muscles attach onto the humerus on the greater and lesser region, and needle onto those space. Again, typically teres minor not involved, but it can be, so not a bad idea to know how and where to needle there. But infraspinatus, supra, and then subscap. And so I'll leave that up, but let me stop this share right here. And from here, give us 1 second. We're going to change some settings and go mobile so that we can start some surface anatomy. Okay, so obviously one of the most important things are our structures. Given this location, we don't want to needle into the lung field. So first thing, I'm going to locate the lateral border of the scapula. I've already done that. I'm going to find the inferior angle, and then the medial border as it comes up. So I'll make that direction here. Of really good importance, we want to know the location of the spine of the scapula. There's a superior and inferior border there. We will come out a little bit later, and we're going to identify the acromion as we are headed here. And right now, these are our biggest areas of concern. On the medial border, we'll find teres minor coming here. Obviously, infraspinatus is here, and then supraspinatus is here. On the anterior aspect of the scapula, we'll find subscap right here. So while we're in this position, not completely prepared. Bear with me while I glove up. People get concerned and a little afraid of the rotator cuff. Rotator cuff is one of the easier, more simple areas for dry needling. It is one of the more responsive that we can see with our patients. And there's not many people that come in clinically that we see with a rotator cuff dysfunction that we won't end up doing dry needling on them. So let's do infraspinatus first. So again, our key is going to be the spine of the scapula, and this is just going to be anterior to posterior, or posterior to anterior. I'm going to drop one finger breadth caudal from the spine of the scapula. I'm going to drop, and I am going to use the surface of the scapula as the backdrop. The infraspinatus is usually a little bit thicker, a little deeper than you may think. That is a 3 centimeter needle. I went very deep to hit the backdrop. So sometimes it takes a little bit more depth, especially on a larger person. On teres minor, I'm going to get all up in the business. I'm going to palpate for that medial border of the scapula with my fingers. And I'm going to move if we split this area in half, then I want a needle in the mid part of the upper half. My fingers are there and I've identified that border. And so I'm going to drop right in. And my fingers I'm going to palpate to make sure that I'm not coming through the skin. I'm also palpating the rib cage with my fingers to make sure that my angle is not going into the rib cage. Now I'm going to release, and the needle is going to be pointed towards the rib cage. However, its placement I've already assured through my placement. On supraspinatus, again, I'm going to palpate for the spine of the scapula. For a person just starting to needle, I'm going to needle onto the spine of the scapula, just in a perpendicular to that surface. I'm going to move the skin superiorly, and then I can advance the needle down into the supraspinatus. I can retract. Now the needle placement is there in the muscle. As I relax and let go of that, the needle is bent in that area. It is not in the lung field. It's just as I retracted the needle, it is repositioned. As we are pointed forward, the needle angulation is posterior. So those are those three. Now we will remove and dispose of these, and then we'll get subscap. If you don't mind, let's go hand behind back. So in this position now, my landmarks have changed since he moved his hand behind his back. But I still have this medial border of the scapula. Here's the inferior angle and the border here. I can palpate and I can see where that inferior border, that medial border is. And so my angle is going to be almost parallel to the skin. I'm going to place it, tap, the needle is in. I'm going to slide underneath the scapula and land on the scapula as the backdrop. And there we have subscapularis. Again, that one you can move that back. That one can also be done in the supine position on the anterior aspect, but it usually is a little bit more tolerable in this position. All right. Now, if you can, I'll have you sit. And we'll just sit right here facing this way. We're over here. You know what you've got? So my subject has some actual shoulder issues. So we're going to come in, again, identify our landmarks. Lateral border of the acromion. I'm going to follow it around to here. On the back side here, I see the spine of the scapula here. Clavicle is coming up and over with our posterior V-notch right here, anterior V-notch right here, and with the acromion coming on around to here. Further medial, we'll find coracoid, and then we get into the humerus below. So one aspect that we get concerned about, if you'll go ahead and flex for me, is the bicipital groove. Okay, just let it relax. So we have the bicipital groove, location of the bicep tendon coming up as it attaches on the glenoid. The subscap attaches medial to that location, and then we know the fibers of supraspinatus are going to come here. So subscap is going to come to this area. Infraspinatus, we know the fibers are coming here. And then teres is just right below to there. So there are 1, 2, 3, 4 locations or a myotendinous or tenoosseous junction. And depending on the nature of the pathology, you could be needling the myotendinous junction or the tenoosseous junction. The distance between them is a very short tendon, so the distance is very minimal. You may find that you need a little bit of both in this regard, and it's all on palpation. So I will probably needle infraspinatus attachment and teres minor at the same time, because how certain am I that I'm needling which one? It is very difficult to determine. And so I'll needle into that area. My backdrop is the humerus. We'll come on to the supraspinatus. And again, humerus is the backdrop. And then lastly, the subscap, medial to the bicep tendon. With humerus as a backdrop. So for treatment of, I'm going to go ahead and pull these. For treatment of a rotator cuff, especially rotator cuff with tendinitis. Thank you. With tendinitis, I will definitely want to address each of the individual muscles that seem to be responsible. More often than not, number one is going to be supraspinatus. Close second is going to be either subscap or infraspinatus. And then lastly, occasionally you get the teres minor. Occasionally it is simply a muscular issue, which reducing that muscular tension can be a big plus. More often than not, if it's a little bit more chronic of an issue, then we do need to come deal at the attachment on the humerus itself. Again, we're not really covering this time. If that situation has gone on long enough, we're probably dealing with some impingement, in which case we need to deal with the ligamentous structures and the subacromial subdeltoid bursa themselves. And that's always followed by some good manual therapy, active movement, and motion. Any questions, feel free to email me, give me a call, send me a message online, and I'll be glad to answer more questions. Thanks for your time.